In section 1, we're going to be discussing a review of the fluid and electrolytes balance, acid-base balance, which will of course include metabolic and respiratory acidosis, and we'll then do a little bit of a review after that with some test questions. So I'd like to first begin by talking about what fluid and electrolytes is all about. Remember that when we look at fluid and electrolytes, you're memorizing which compartment does what, but more importantly, how is it affected and what affects it the most? For example, is it age-related? Is it gender-related? Or is it, in fact, related to the physiological changes that are occurring? So let's look at then, if we are looking at an individual who is an adult male, that they have a larger component of fluids than a woman does. However, the ones who get into trouble the most frequently are the infant, the very young, because they have about 80% of their volume is fluid, and the very old, because their body doesn't adapt as well to the changes that occur in fluid shifting. So when we look at how that is applied then, we look at the fact that we need to be careful about IV fluids, how much fluid we're giving them, and of course monitoring what is in and out. So let's begin by looking at what you need to really remember. If you go back to anatomy and physiology, you know, of course, where the electrolytes are. You know, of course, what affects the electrolyte shift and the importance of those. You need to take a look at your textbook, and if you look at what is in the extracellular versus the intracellular compartments, it would be easy to see by adding or subtracting some of these components that the fluid would shift. But important in this is, let's look at what then the fluid and electrolytes really do. If we look at electrolytes, it also helps to promote neuromuscular excitability. What does that mean? If you have too much potassium, for example, then the heart is going to fibrillate. That's a muscle. So it is important to remember that that's going to be the effect on the cardiovascular system. It will maintain fluid volume, as we said before. If you add sodium or subtract sodium, then what's going to happen is you're going to see a fluid shift. Of course, it also helps to regulate acid-base balance, and that's what we're going to spend most of our time on this morning, is talking about fluid and electrolyte balance. Now, asks these questions for a variety of reasons, one of which is safety. Safety in that you are going to be administering IV solutions, which of course, remember, is a medication, and that's important in understanding that if you add or subtract sodium from those fluids, that it will also alter the fluid volume in the compartments within the body. We need to look at that because we need to remember what is isotonic, and remember that's the 0.9% sodium chloride. What is hypertonic, which would be adding sodium, and of course hypotonic, which would be the opposite. Important also is to remember that because we add sodium and or subtract sodium, it will change the pressure gradient and thus draw fluid to it. So questions about what is the safety issue with regards to adding or subtracting sodium from these fluids and administering that. Now, there are other things that also go along with fluid volume and fluid maintenance. The first thing is that we remember that the body is a whole system. Therefore, we have to look at all the different components that would help us to either retain or get rid of fluids. The kidneys play a major role because they control fluid and electrolytes by secreting renin. And if you remember what renin does, renin is that component that will trigger angiotensin and, of course, angiotensin II, which will either retain or secrete fluids and thus raise or lower blood pressure. The lungs also control CO2, which, of course, has to do with our acid base. But remember that if you have a patient that is, or a client that is breathing very rapidly, they also are losing fluids because of the volume of vapor that they're blowing off. So the water vapor also has something to do with rapid respiratory rate. You lose fluids through skin, and the people who get into trouble with that are those individuals who don't sweat. If you can't perspire or you don't get rid of fluids and your core body temperature goes up, your body has no way to regulate temperature, So it is an important mechanism in not only temperature control, but in the intake and output of fluids. And of course, the last part is hormonal control, ADH and aldosterone. They also play an important part. Now, when we look at assessment of fluids, there is what I call a fluid volume management type of assessment that is universal for all patients, whether they are going to lose fluids or whether they're going to have too much fluids. You're going to still do that same type of assessment parameter, which is daily weight, which is the most important type of assessment that you can do. It's also skin turgor, and of course intake and output is very important. Now, when we look at what the age of the patient is, it may also be that, for example, if it's an infant, you would check fontanelles, and of course the orbits of the eye. That is going to be the major part of your nursing assessment. In addition to that, we would also add specific gravity. Urine-specific gravity is also very important. The reason for that is because it can give you a very quick and very easy way to measure whether your patient needs additional fluids or has too much by whether the urine is either concentrated or too dilute. Now, there are many reasons and causes then, if we want to look at your text and look at the causes for the patient becoming dehydrated or to have a decrease in fluid. The most common, and when we go through all of this med-surg review, I just want to remind you that there will always be a menu of a whole group of things that it could cause. What common recurring healthcare problems? Therefore, I am going to point out to you those that you would most frequently see. I would encourage you to perhaps put a little star next to those. The reason is because no one can remember everything there is to remember about either the nursing interventions or all of those things that you need to do, but the most important ones, or those that are the most common, are the things that I will test. Therefore, those are the things that you should be remembering. So when we look at what we see the most frequently, what are they? Fever. Patients who have fever, remember we talked about that core body temperature going up, and of course you're going to lose fluids, especially either through perspiration or, of course, diuresis. Vomiting is also a major problem, or a very common one. And remember that when we look at vomiting, not only are you losing fluids, but you're also losing electrolytes, and that also becomes a major issue. And we'll talk about that in a little while when we talk about metabolic acidosis and alkalosis. Diarrhea also becomes a problem that is fairly common. And remember that when you have lots of those GI upsets, and think about this food problems, ingesting viruses, bacteria, those types of things, they almost always cause vomiting and diarrhea. And so because they're so common, you're going to see those included. Increased urination or urinary output, and it could very well be because the patient is either taking diuretics, which adds the additional portion of electrolyte imbalance, or it could be because they have eaten foods that have also had the diuretic effect, such as caffeine. And we also need to remember that soda or pop is also included in that, even though we don't always think about it that way. So we've already talked about what the nursing assessments are. Therefore, if we look at the nursing assessments, then we look at, these are the major manifestations then of this disorder. Weight loss. Remember we said that monitoring their weight is the most important thing in measurement of fluid volume excess or deficit. Therefore, weight loss or gain, when we look at the opposite, is going to be one of the parameters that we need to look at. Poor skin turgor, and remember you're going to use yourself as normal, and you're going to test your own skin turgor to determine whether in fact it is normal, and then assess or evaluate the patient's skin turgor against your own. And of course, increased respirations, urinary output increase, and we've already discussed that. So when we look at the last parameter then that we haven't talked about, it is intake and output. Measuring intake and output or monitoring intake and output is also a very important nursing assessment or part of the nursing intervention. The reason for that is because if we're going to try to control fluid volume intake or fluid loss, then we have to have a good idea as to the amount that they're taking in and, of course, what is also going out. Now, when we have a patient who is dehydrated, we're going to be correcting the cause. Most of the time it is that we make the patient NPO, or we give them nothing by mouth, and we replace fluids. Now, we've already talked about those fluid replacements, so it would depend then on looking at the whole picture, because again, remember, you need to look at the lab values and so forth. So based on what is in those lab values, that will be the type of solution that will be administered. They might say this is the patient's sodium and potassium level, for example. The physician has ordered this type of solution, D5¼ normal saline, and of course they may also then say that the nurse which intervention would the nurse perform first, and it may be that they need to question the order because it's the wrong solution based on what the nurse is seeing. Remember that we are not only following the physician's orders, but we are critically thinking. And when we critically think, we take all of those things that we know and we apply them to the situation. And we make the decisions then based as to whether we are going to have to perform some intervention or we're going to call the physician. We don't just blindly follow orders. That's part of the critical thinking. Now, the opposite of fluid volume deficit is fluid volume excess. And the most common reason is a patient who has CHF or congestive heart failure or pulmonary edema, and IV fluids. Too much IV fluid also is one of the major causes of excessive fluid. Now, that's one of the reasons, by the way, that an IV pump was first developed to make sure that patients who are critically ill don't have an excess of fluid or don't get an excess of fluid. And certainly it's also because they are now getting all these other drugs that need to be accurately delivered, and that is a much more accurate measure or way to deliver medication. Now, if I had a patient who has too much fluid, the first thing that you're going to see, you may see the weight gain is also going to be there. So that's a little bit more subtle. Remember, though, that if they're old, or very young, that is going to be a very easy measure for you because it's going to occur a little bit more rapidly. A few ounces or a pound or two may make a difference. However, you're going to hear crackles or rales. That's the old word, used to be rales. So some textbooks still have that. But we use the term crackles now, which means you're going to hear gurgling or fluid in their chest, in anterior and posterior assessment of their lungs. Another thing that you're going to see is an increase in blood pressure and in pulse rate. Whenever you have an increase in volume of fluid that is going through the system, blood pressure goes up. It doesn't matter what caused it. Remember, that is the outcome. That's what's going to happen, and that's what you're going to assess. The other thing, of course, is that you're going to get a headache. Think about what happens if I eat a bag of potato chips. I'm going to retain sodium. Now, if I have too much sodium on board, what's going to happen is as the fluid volume goes up in my body, it's going to put pressure on all of the vessels, including those in my head. And so I'm going to get a headache. I'm going to gain weight. I'm going to feel lethargic. Think about what happens to you. If that happens to you, it's the same thing that's going to happen to your patient. And so they may start to complain of a headache very early on. Very late in the fluid overload is, think about, again, and we're going to talk later on about a patient who has congestive heart failure or who is in pulmonary edema. But whenever we look at late signs, we're going to look at neck vein distension. This is systemic. Whenever you have systemic failure or right-sided failure, remember that that's what you're going to see, that neck vein distension. Your heart is going to beat very rapidly. And in a couple of moments, I'm going to talk a little bit about what we can use, what I call a perfusion assessment. And that's going to help you, I think, throughout this whole series to determine what is actually going wrong with this patient. And of course, when we look at pitting edema, remember, simply means that usually we're talking about the lower extremities. And when you put your finger into the ankle or the top of the foot, a depression is made. And based on how long it takes for that to respond, once you release the pressure on the spot, you count +1, +2, and so forth. So those are very common signs of a patient who has fluid overload. These patients, again, are weighed. You're not giving them as much fluid. You're going to, in fact, restrict the amount of fluid that they get, and, of course, monitoring intake and output. Now, if you have a patient regardless of the cause, that has an increase in fluid volume, then remember we talked about that pressure on the vessels. In addition to the vessels and the inside of the body, what also happens is that it puts pressure on the skin. And so if the skin is taut, it is more susceptible to breakdown. Therefore, good skin care is extremely important. So before we talk about perfusion, I just want to mention something about pH. However, you need to know what that normal value is. And remember, 7.35 to 7.45 is normal pH. And when we look at metabolic acidosis and alkalosis, that is what is going to be one of the most important assessment parameters that you can perform. Now, I just want to stop for a moment here and talk about perfusion. And you're going to see a diagram that talks a little bit about perfusion here, because I think if we get this clear in our head, then we are going to it will make our life a lot easier, or make your life a lot easier when you're studying even the renal function, liver function, and so forth. It all has to do really with a patient who is in the body and system in failure. And remember, again, you could have failure for a number of reasons. You could have failure because of hypovolemia. You could have a patient who is bleeding profusely. You could have a system failure. But regardless of what the failure is, the body starts to respond in a very systematic way. Now remember, this is a very simple way. I'm not going to get into the cellular level and all of those things that are happening. But just think about this, and you'll, I hope, realize how simple the process is to follow. The first thing that you normally see is a tachycardia. The heart will start to beat faster because the body is saying, I don't have either enough oxygenated blood or I don't have enough fluid, so I need to do something about it. So the first thing that happens is the heart starts to beat faster. In conjunction with that, respiratory rate goes up. So you have tachycardia and you have tachypnea. And both of those things are as a response to, again, either not enough fluid or not enough oxygenated blood in the system. If that doesn't work, the body says, this isn't working, we need to do something else. What are we going to do? Well, the next thing that happens is that the lower extremities kind of shut down all of their vessels. We have decreased circulation to the lower extremities because what happens is we want to make sure that all of the essential electrolytes, fluids, and so forth are in the upper extremities or in the heart, lungs, brain, the vital organs. So you have vasoconstriction to the lower extremities. That's one of the reasons we don't give an IM injection to a patient who is in shock or who is hemorrhaging or who has had a trauma, because it'll just sit there. It won't go anywhere because there is no perfusion. Remember, we have a problem of perfusion, and I just want you to keep thinking about that. When that doesn't work, what happens next is the body saying, listen, you need to do something else for me. You're breathing faster, you're beating faster, you've shut down the circulation. It's still not working. The kidneys then will respond by conserving fluid. So they shut down, or they start to shut down. And the patient then, or the client will then develop oliguria. So decreased urinary output is like the fourth step in the body trying to maintain homeostasis. And remember, that's what the body will always try to do before it actually fails. So the body is now in failure, and it got to the point where it shut down the kidneys, and the kidneys are conserving fluid, and there's still not enough fluid or oxygenated blood. So the body says, you've done all of these things, we have one last ditch effort that we need to make. And if you think about this, what happens to a patient who has had a heart attack, what happens to a patient in renal failure, is that the body will stimulate bone marrow to make more red cells to try to maintain homeostasis. So this is what happens once the kidneys have conserved fluid. The next step is stimulate the bone marrow to develop more red cells. And remember that when that happens, what happens to the blood is that the blood gets thick and the heart has to work harder. And so if it continues in failure, it's just like a vicious cycle, and eventually the body will shut down altogether. That is the problem of perfusion. It doesn't matter what the cause is. I want you to stop and think about that, because whenever we are going to talk about certain problems as we continue on in this medical review, I'm going to refer back to this. And I'm going to say, do you remember what I said? Tell me what you think is going to happen next and what is the next assessment parameter. And that will be very important. The next topic then that we're going to talk about, which goes along with perfusion and all of those things that we've already talked about, is something that I'm sure is near and dear to all of your heart, and that is metabolic acidosis and alkalosis, and of course, respiratory acidosis and alkalosis. Now, there is a table that we'll be talking about, and in the table, remember, we're going to be looking at the first part, which is acidosis. We're going to be looking at metabolic acidosis, and take a look at that table, because what that's going to tell you is exactly what's happening in metabolic acidosis. Now, while you're looking at that, think about what causes acidosis. Remember, it is a base bicarb deficit. That means you have an increase in hydrogen ion concentration. You have more hydrogen ions now than you had that when homeostasis or that balance was maintained. The causes, again, the most frequent is diabetic acidosis, renal failure. Those are the two that are the most common that you see. Certainly it could happen if you have diarrhea, but remember that it's going to be a long-term diarrhea. It's not going to be a diarrhea of one or 2 days. The other, of course, is if you have a systemic infection that becomes overwhelming, the patient then is at risk for metabolic acidosis. So those are the most common reasons, but the two that I mentioned to you first are those that you should star, as I mentioned before. The earliest sign, and again we need to look at when we look at manifestations, remember that I'm going to ask you either whether this is on an initial assessment, they're going to ask you whether it is after you've evaluated all of the lab values, because remember when you look at the client, for example, you can't see a pH below 7.35 when you're looking on initial assessment. That is after you've evaluated lab values, then you can tell that the patient's pH is below 7.35. Confusion, headache, stupor, those are the things that you see initially. The client will complain of a headache. They will then become confused and perhaps become stuporous. And of course, if no interventions occur, then they will lose consciousness. But remember that is, again, later on. You've hoped to intervene prior to that. So if you have metabolic acidosis, remember then from that diagram that you're seeing that the pH will be down, the HCl3 will be down, and of course the symptoms will include those that we've talked about: disorientation, change in the level of consciousness, small respirations, which are an irregular type of respiration, and they are very slow, and eventually a muscle twitching as a result of that decrease in the HCl3. Now, the next part of that then will be that we need to look at what the interventions are. The interventions are very simple. Certainly it's going to be to correct whatever the cause is. So if we look at what we said would cause this type of disorder, renal failure and so forth, then we're going to treat that renal failure or treat whatever that condition is, and that should correct the metabolic acidosis. The other thing that's very important is to give sodium bicarb. And again, I would star that because sodium bicarb is ordered anytime you have a patient in acidosis. In some institutions, it's a standing order that if the patient develops these symptoms and is in metabolic acidosis, you automatically give sodium bicarb. Now, the nursing interventions also include monitoring potassium levels. And again, when you have acidosis, you will have a fluid shift, and that is why you need to monitor those potassium levels, because when you have a fluid shift, potassium is going to go from where it should be to where it shouldn't be. And that, of course, is that it's going to be outside of the cell rather than inside. Now, promoting good air exchange, your text says to promote good air exchange, and you know how to do that. This isn't telling you how to do that, but you already know how to do that. And that is putting the patient in a semi-Fowler's position. using their incentive spirometer, coughing and deep breathing. All of those things will increase the alveolar sacs on the lungs, which will promote that air exchange. It will promote it at the cellular level. Therefore, that's important for you to do because, again, acidosis means that they have too much acid and you want to blow off the CO2. So by doing that, you're going to have to expand the amount of volume of exchange from oxygen to carbon dioxide. Now the next thing is metabolic alkalosis. And alkalosis is a base bicarb excess. We have too much bicarbonate, which means then, if you think back to what we gave with acidosis, we would not give sodium bicarb then to a patient with alkalosis. The most common cause for this is vomiting, because there's an excessive loss of chloride, and then of course there'll be the shift of electrolytes. The other is, and again this is the other thing that you need to star, is gastric suction. We sometimes, when we're taking care of a patient who has an NG tube or is hooked to suction in some way, we forget that we're taking all of those electrolytes out as well. Anything that's sitting in the belly or in the abdomen is also being sucked out into this container. Therefore, we are going to be monitoring their sodium and potassium levels and their chloride levels when we have a patient on gastric suction. The other patients that get into trouble with this type of disorder is a patient who is on long-term diuretic therapy, especially those that are potassium depleting, like Lasix, and we'll talk about that at a little later. Now the manifestations, that is, those are the things that you're going to see. The initial are central nervous system symptoms. They are confusion, irritability, agitation, and eventually coma if no interventions occur before that. The patient will develop shallow respirations, and again, those Kussmaul respirations that we talked about earlier, that will be evident here as well. Tetany occurs, again, as you have that electrolyte shift, and when we look at the endocrine system, we'll talk again about tetany and how to assess for that. Now, again, restoring the fluid volume, treating the underlying cause, those are the same treatments for this type of disorder as for metabolic acidosis. Treating the cause, monitoring potassium levels is also extremely important, again, so that you can see whether, in fact, the patient is in fluid balance or fluid and electrolyte balance, and preventing the loss. Now, I just want to stop for 1 minute and talk about that for a moment, because it's important to remember that any time you have a disorder, not just like this one, but any of that we talk about, prevention is number one. Preventing it from occurring by monitoring the patient who has an NG tube, a G tube. It doesn't make any difference what type of tube it is, whether it's or the IV fluids. If you are monitoring it and you're keeping on top of it by making sure that it is running correctly, that you're monitoring lab values, some of these things will not happen, and that is the most important thing, and so address that. They look at nursing assessment and, of course, making sure that they evaluate or synthesize or analyze what they're seeing and applying it to that situation. Now, the next topic is respiratory acidosis. Now, I want to just remind you that when you see a rapid change in your patient, that rapid means it's respiratory. If you see a rapid change in acidosis or alkalosis or in the patient's condition and you're suspecting that it's acidosis or alkalosis, it always is respiratory because metabolic changes take a little bit longer. So the rapid changes are respiratory, and the R's go together, rapid and respiratory. It is because they have an excessive carbonic acid. There's too much carbonic acid, which means that they're retaining carbon dioxide. So if I'm retaining carbon dioxide, it means that I am not able to exchange that gas or the oxygen and CO2 at the cellular level. It means I can't take a deep breath. So what is the usual cause for that is something that would cause an obstruction or prevent you from taking those deep breaths, like pulmonary edema, like pneumonia. And by the way, pneumonia is probably the number one reason for this, that the patient starts to develop respiratory acidosis. Now, Patients who have COPD, and we now call it CAL, or chronic airflow limitation, those patients also are chronically in respiratory acidosis. Therefore, we need to make sure that we are monitoring them more closely. The earliest manifestations or earliest signs for these patients are confusion, restlessness, and weakness. Those are the things that you're going to see first. They'll forget what they're doing. They'll become very restless and agitated in bed, perhaps. As it progresses, then headache will develop and eventually coma. Now, again, remember that if we're looking at lab values, which is looking at the whole picture so that we can apply our knowledge to what's happening to this patient, then we'll see the pH falls below 7.35 and the PCO2 is above 45 millimeters of mercury. So, again, remember that those are the things that you're going to assess if you're looking at the entire picture, not the initial assessment. And so another very important point when we're reading is to make sure that we read all of the words, to make sure that if you're looking at, is it the initial symptom that they're looking for? Is it a later sign? Or is it after evaluating the information or the data that you've collected? Those are the things that will help to ensure your success. Now, the chronic patient, the patient who, remember we talked about the one who has COPD or CAL, these are the classic signs of COPD. The PCO2 above 45 millimeters of mercury. They will develop tachypnea, dyspnea, and eventually a weight loss. Eventually a weight loss. And that is, again, because their metabolic rate is so high, because they are breathing so rapidly that their metabolic rate goes up, and so they start to lose weight because they're using their stores or their reserve, and thus there's a weight loss. Now, in these cases, when you have acidosis, respiratory acidosis, you're going to give sodium bicarb. Again, anytime you have acidosis, you give sodium bicarb. If it's alkalosis, we're going to do something different. Good air exchange or respiratory exchange, we've already talked about that, positioning your patient, making sure that you use the incentive spirometer, doing coughing and deep breathing, getting them up and ambulating them, making sure that they are able to exchange that air so that they have a good airflow and, of course, then get rid of some of that acid. And, of course, bronchodilators. Now, bronchodilators are ordered by the physician, and the reason that they're ordered is, again, to promote that air exchange. When you use bronchodilators, you're going to increase the surface that the air exchange takes place. And we're going to talk about bronchodilators when we look at the respiratory system and how to use them and so forth. So we'll talk about that again a little bit later. Now, we also know that by monitoring O2 sat, we can determine oxygen saturation. That's an important parameter, and we're going to use that when we look at any patient who has a respiratory problem. But the most accurate measure of the fluid and electrolytes, or the electrolyte balance, is by monitoring arterial blood gases. But you do need to know what those normal values are so that you can assess whether, in fact, they are within normal limits. There will be a slide that will also have those normal values that you should be seeing right about now on your screen. The slide will show you the normal values for respiratory and metabolic acidosis and alkalosis. And I would encourage you to stop this at this point and just take a look at it so that you can see what the changes are that occur. And we're going to talk about that again in just a moment, because I want to give you some suggestions on how to remember whether it's alkalosis or acidosis. Let's look at the last piece of this before we talk about the changes, and that is, we'll talk about respiratory alkalosis, which is a decrease in hydrogen ions. The client who has this condition usually is one who is hyperventilating. And you see that all the time. A client will come in to the emergency room, or a client will come onto the unit, and they're either frightened or they're in a lot of pain, and so they breathe very rapidly. And as their respiratory rate goes up, the client will say to you, one of the first things that they say is, I can't feel my mouth. My mouth feels like it's going to sleep. Or, I can't feel my fingertips. My fingers and my hands feel like they're going to sleep. That's a classic sign of hyperventilation, and it means that they have a decreased oxygenation to their periphery. What you want to do is slow their respiratory rate down. And how we do that is, certainly if you have a paper bag, it's a wonderful tool, because you just put the paper bag over their mouth and tell them to take some deep breaths into it, and it will slow their respirations down because they're rebreathing their carbon dioxide. If you don't have any paper bag, you can take your cupped hands, put them over their mouth and nose, and tell them to breathe in their hands that way, and that will, again, slow down their respirations. The patient could become unconscious. That's usually a later sign. Again, the first thing is that circumoral numbness, or the numbness around their lips and mouth. And if you were to evaluate their blood gases, then in their blood values, you're going to see that there'll be a PCO2 below 35 millimeters of mercury. Now, if the patient becomes hypoxic or has a decrease in oxygen saturation, then you're going to give them oxygen. But remember that some of these individuals have pneumonia, which means they have an obstruction and they are unable to exchange air. So by giving them oxygen, you may further decrease their respiratory drive. So you want to be very careful when giving oxygen. There is an area in your text also that talks about blood gases. And again, it talks about all of the components of blood gases. I'm not going to go over all of those. Please make sure, however, that you do read them. That is really from your anatomy and physiology. You're going to draw on that base and remember what all of those components mean. It is important, again, when we look at evaluating a patient who has metabolic acidosis and alkalosis. Now, I want to, before we move on to anything further, I just want you to look at the next slide that is up on your screen, because that's going to talk about the difference between respiratory and metabolic acidosis and alkalosis. As you remember, a few minutes ago, I said I was going to give you some way to perhaps remember that. Now, if you look at this, if you look at respiratory acidosis and the word opposite, you know that you see that there are P's in both of these words. So the two P's go together. Respiratory is opposite. So that means that the pH and the PCO2 in alkalosis will be going in opposite directions. The pH and the PCO2 in acidosis, as you can see on your screen, will also be going in opposite directions. So that is very important because it will help you when you're looking at a test question. If you could remember that they're opposites in respiratory acidosis, then you'll be able to remember what you're looking at and pick out whether it's the right answer. When we look at metabolic acidosis, then they're equal. So metabolic, ME, means equal. And if we look at that, pH and HCO3 are equal. Are going in the same direction in alkalosis. They're both going up. If we look at acidosis, the pH and the HCO3 are decreasing, so they also are going in the same, or they're equal in the same direction. So if you take a look at that and make sure that you put a little star next to that, because that's going to also help you then to remember what is happening in metabolic and respiratory acidosis and alkalosis. So to recap, there's one other important point that I didn't talk about earlier when we looked at fluid volumes and metabolic acidosis and alkalosis. And that is that when we looked at fluid volume, we talked about IVs. And one of the important things to also remember is safety issues. And before we recap and talk about all those things, and so we can go into talking about some test questions, I think it's important for us to remember that those safety issues may include making sure that the pump is correct, making sure that the right solution is up and that it is at the right rate. Also important is to make sure that if you're going to put any additives into that IV bag, make sure that the patient's systems are working. So for example, if we have a patient and the order reads, if we have a client and the order reads to add potassium to that IV solution, we want to make sure that their kidneys are functioning before we add the potassium. So Remember that we want to make sure the patient voids before we add potassium to the bag, to the IV solution. Therefore, no P, no K. If the client isn't voiding, then you want to make sure that there's no potassium added to that solution. We also know that patients who have a low sodium will usually start off with confusion. So those are two ways to look at sodium and potassium also. Now, to recap, what we've talked about in this section is we have looked at metabolic and respiratory alkalosis and acidosis. We've looked at arterial blood gases. We've looked at body pH. We've looked at fluid and electrolyte balance and how we can assess for that balance and the interventions that nurses can employ. And of course, we looked at that big picture called perfusion, where we were able to look at how we can assess a patient generally who has a fluid loss or an electrolyte loss. So those are the important points that we talked about. This next section then will be doing some test questions that relate to the topics that we've just discussed.